Hi everyone, Dr. Sami here from Connolly Hospital. I'm working right now as SHO Anesthesia via CPSP HSC training program. I'm going to present my case report regarding the anesthetic management in a patient with Berardenilli-Seip congenital lipodystrophy. So what this disorder is, this is an autosomal recessive congenital disorder that is 1 in 12 million. This is characterized by lack of adipose tissue with resultant dysregulation in carbohydrate and lipid metabolism. There's much increased gluconeogenesis along with decreased insulin-mediated skeletal muscle glucose uptake. These patients are low on serum leptin and adiponectin level. These patients have lipoatrophy and acromegalic features, as you can show on the right side in the picture. These patients have hepatomegaly and elevated triglyceride levels up to 80 gram per liter, insulin resistance. These patients have hypertrophic cardiomyopathy, psychomotor retardation, hirsutism, precocious puberty. Going to the main part, so we have this patient, 12-year-old boy, 50 kg weight, 156 centimeter height, scheduled for open reduction and internal fixation of femur. This patient has diabetes mellitus, hypertension, portal vein thrombosis, left ventricular outflow tract obstruction, hyperthyroidism, raised INR of 1.66, delayed milestones. We have transfused 2 fresh frozen plasmas on the OT table before injecting the spinal anesthesia. Midazolam and ketamine were being used as a pre-medication. L4, L5 level was used for injecting the spinal anesthesia. 27 gauge via the 27 gauge Whitaker needle, 0.75% hyperbaric bupivacaine was being used, and patient was kept in lateral position for 7 minutes before making the supine position. Propofol was used for sedation, and the intraoperative course was uneventful. Postoperatively, the patient was monitored strictly, and after 5 hours with modified Bromley score of 0 and post anesthesia discharge score of 9, he was being discharged. So let's go to the discussion part. Due to the CAP3 gene deficiency, these patients are considered at risk of developing malignant hyperthermia as the association of this gene with the ryanodine receptor gene and calcium genes. Due to the absence of adipose tissue, resulting in brain being disproportionately affected by the anesthetic agents, we will recommend to avoid highly fat-soluble anesthetic agents. We have only 2 case reports of general anesthesia for these patients, no spinal anesthesia case reports, and one of them general anesthesia case reports have delayed emergence. So keeping that in mind, we opt for low dose spinal anesthesia to avoid excessive sympathectomy and high level of block in surviving the hemodynamic instability and maintaining a fixed gradient. We will recommend to maintain intravenous volume, good intravenous volume, and freen and feen should be kept in hand for hypertension, guided by the invasive monitoring. Although we had used a propofol for the sedation, but we have used it at very low level, making up to 0.15 gram. But on hindsight, we will recommend the use of dexmedetomidine for sedation and also for the induction of anesthesia, along with other less fat-soluble anesthetic agents where needed. Thank you.